Hello, and welcome to this Practicing Clinicians Exchange podcast. I'm your host, Dania Reynolds. In this episode, we talk to Susan LeLacheur, Physician Assistant, Professor, and Director of Equity at the George Washington University School of Medicine and Health Sciences. She'll discuss issues with racial disparities in HIV PrEP and strategies to close these gaps. For more information about Susan LeLacheur, along with other podcasts, downloadable slide sets, and a point-of-care resource hub, visit the website in the show notes. Now let's get started and hear what Susan has to say about racial disparities in PrEP.
Hi, I'm Susan LeLacheur, and I'm a professor at the George Washington University Physician Assistant Program, and I've also been an HIV care clinician since 1987. I'm very excited to be talking to you about PrEP and particularly about racial disparities in care of people and offering and keeping people on PrEP. Racial and ethnic disparities have been a problem in the HIV epidemic since the very beginning. Recently, the National HIV Strategy for the United States for 2022-25 was released, and within that strategy, there are 4 goals, 2 of which are really pertinent to the topic today. There is one goal that is the reduction of racial disparities and health inequities, and another is the prevention of new infections. And another subtext of preventing new infections is to increase PrEP coverage, pre-exposure prophylaxis. Now, in terms of disparities, African Americans make up 40% of both current infections and new HIV infections, but only 13.4% of the U.S. population, while people who identify as Hispanic or Latinx make up 29% of new infections, but only 18.5% of the population. In contrast, white or European Americans make up 60% of the current U.S. population, and only 25% of new infections. New infections among Black women are 11 times more frequent than new infections among white women. And these disparities are not associated with behavioral differences. So what all those numbers indicate is there are huge documented disparities in the proportion of people in underserved communities who are getting HIV, and they're increasing so that the current percentages, although high relative to white or European Americans, are nothing like what they're going to be if we don't start addressing this problem. Manya Magnus, formerly of George Washington University Public Health, during her time there did a study in the District of Columbia, which is one of the CDC's hotspots of HIV infection, places where we have a lot of HIV infection and need to really focus on risk reduction. She did a study with colleagues looking at Black and white men with HIV infection and comparing risk behaviors and other factors. And what she found was that Black men were much higher risk of getting HIV infection despite lower frequency or relationship to behavioral risks, such as unprotected anal intercourse, or sociological risks, like being in jail, that even with lower levels of those things, they were at higher risk of getting HIV. A lot of this has to do with just the amount in the community, and that in turn has to do with a number of other factors. Major one being access to health care that is comprehensive and appropriate to the people in need. There's a lot of stigma in the community, and that stigma is often reinforced by healthcare providers and systems of care. We've got to start changing that. And there are a number of ways we can do that. Medical practitioners, for one thing, need to include larger numbers of people of color, people of the communities most at risk right now. But that's going to take years to decades to fix. There's a huge barrier right now in terms of access to clinical education. It's beginning to be addressed, but it's not something we can count on right now. And we need to address these things right now. So in the meantime, we have to diversify our workforce in other ways by creating teams of care that include addressing a lot of the barriers to care, such as linkage to healthcare coverage for things like pre-exposure prophylaxis. There are many programs available, but they have to be addressed in ways so that people know how they can access the medications they need and maintain access, not run out of medications, have a way to easily get back on a medication if they do run out, and a place that they feel comfortable going and calling. With pre-exposure prophylaxis, there are a lot of follow-up visits that are needed for STI testing and for testing for HIV, of course. These need to be addressed as well. The healthcare has to be easily accessible and in a place where people feel comfortable going. Now, how do we get to these populations? Well, besides extending healthcare so that it's available to people in need, one thing that's not being done as much as it must be done is testing for all who need it. Currently, there are over 13% of people who have HIV don't know they have it. And it's been since 2006 that the CDC has recommended that all adults, people over the age of 13, be tested at least once for HIV. Primary care clinicians need to be doing that with every patient. And for those at higher risk, doing it more often. And you're not going to know if somebody's at higher risk unless you do the test and ask for a sexual history. In addition, PrEP should be offered to all sexually active patients. And again, you're not going to know your patient is sexually active or in what ways they're sexually active unless you ask. Anybody who comes in with a sexually transmitted infection should be tested for HIV and offered pre-exposure prophylaxis. Anybody who is coming in for birth control, it should be discussed. Might they need to be on pre-exposure prophylaxis? And if so, what is the appropriate type? Prophylaxis against HIV for women may be different than that for men. For some patients, an injectable option of PrEP might be more appropriate, although it requires more frequent visits because the injections at this point need to be given every 2 months with associated testing, and that may be an option. But again, all these things will require team-based approach where somebody is available to help patients with accessing ways to pay for the visits, to pay for the pre-exposure prophylaxis, and a way that works for them to take care of themselves and prevent getting HIV and to make sure that people don't have HIV. Healthcare disparities have been around since the beginning of this country, and we're just beginning to make some inroads into ways to access care for people and make it available and comfortable for everybody. But if we don't take care of those people who are now in greatest need, they will continue to suffer disproportionately from HIV at a time when that's no longer necessary.
Thank you very much to Susan LeLacheur, and thank you to our listeners for joining in. As a reminder, you can review the full Improving HIV Prevention and Primary Care, the Evolution of PrEP program on our website in the show notes. As always, thank you for listening.